Hello, everybody. Welcome to Research America's Alliance member session today. We are so excited to be joined by the recipient of Research America's 2023 Herbert Pardes Family Award for National Leadership and Advocacy for Research. Before we have the opportunity to speak to this renowned physician scientist, and I'm keeping her name silent for now to build up some suspension, I want to thank you for your partnership in Research America as we move together into the new year. So we're going to take a very brief look at this year's Herbert Pardes Family Award winner, and then we're going to have an opportunity to talk with her live, as well as with a colleague of hers who she has very nicely invited to join us. So let's look at this clip.
Hello, thank you for joining us as we recognize Research America's 2023 Advocacy Awards honorees. Our awards honor those who have made extraordinary contributions to the progress of medical and health research. Today, it is my pleasure to introduce Dr. Pamela Davis, who is receiving the Herbert Pardes Family Award for National Leadership in Advocacy for Research. This award recognizes individuals who throughout their careers have demonstrated distinguished leadership and sustained commitment to public engagement and advocacy for research. Dr. Davis is a world-renowned researcher in cystic fibrosis and a leader in community outreach. She's committed to clinical research and to ensuring high-quality medical education. We look forward to learning more from Dr. Davis.
Oh my goodness, it is such an honor to receive an award that is supported by the Pardes family. Herb Pardes is one of the icons of American medicine and certainly an icon of advocacy.
You know, Dr. Davis is amazing because she is a quintessential triple threat. She was an absolutely fantastic scientist in her own right, and her contributions to science have been myriad.
The thing I'm most proud of is directing the Cystic Fibrosis Center at Case Western Reserve School of Medicine for so many years. A few years ago, some investigators applied bibliographic analytics to try to determine which institutions and which investigators contributed the most to development of novel drugs. And one of the drugs that they picked to study was the very first drug that attacked the basic defect in cystic fibrosis. And what they found was that the institution that had contributed the most by their analytics was Case Western Reserve University. And of the 25 top individuals who contributed, 8 of them did their work while they were at Case Western Reserve. It was an incredible privilege and an honor, and I'm very proud to have directed the center during that time.
Not only did she serve as an effective clinician and teacher, she extended her work into the community and literally across the state of Ohio to bring underserved communities into the domain of good science and good clinical care.
Advocacy helps anchor us in the real world. It also helps us create a community and a group around us to enhance and to accelerate our research. You know, there's an African proverb that goes, if you want to go quickly, go alone. If you want to go far, go together. And what advocacy does is allow us to collect groups around us to help us go farther.
Pam, congratulations on this incredible honor. I consider you a colleague and a friend, and there is no one I can think of who would be more deserving of this recognition.
Well, Dr. Davis, we are so excited to be visiting with you today, and we're also so pleased to be joined by your colleague, Dr. Heidi Gullett, Associate Director of the Center for Community Health Integration at Case Western School of Medicine. So I already have some questions that I'm eager to ask you, but I know you guys have pulled together a really dynamic presentation. So we'll have an opportunity to see your presentation, and then we'll have plenty of time for questions from our audience as well as the ones that I'll be sneaking in. So Dr. Davis, please take it away.
Thank you very much. I appreciate the opportunity to be with you today. And I appreciate the opportunity to talk about a topic that's near and dear to my heart, which is the community as part of the biomedical research team. It's become a truism that top-flight clinical research absolutely requires the engagement of the community. Even the federal government has recognized that by the establishment of the Patient-Centered Outcomes Research Institute, which only gives funding if there is engagement of the relevant patient participants. There are many reasons to do this. If you have the patients engaged from the very beginning, you can create a more practical study design. You're more likely to get patients engaged to participate in the research. It may help you to consider the interpretation of the results if you're considering how it impacts the people whom it is intended to help, and it will improve the acceptance of research and the research results and the implementation of the conclusions. I want to give you an example from my own career about the power of engagement to make enormous progress. So I worked on cystic fibrosis, which is a genetic disease described in 1938. And when it was first described, the patients all died in infancy. It was a terrible disease. So by the mid-1950s, these children were collected into centers. Doctors got familiar with it. They became good at taking care of the symptomatic parts of the disease, but they also understood that there was an enormous amount that they still needed to know. And they engaged the families in education about the disease. The families learned about the disease, and the families learned of the importance of research if they ever really wanted to change the course of the disease in their children. So these families got together and established the Cystic Fibrosis Foundation, which not only raised money to support research, but was a strong advocate at the NIH and in the federal government for providing the kind of research support that was really important to find the basic defect and ultimately to deal with it. In addition, the families recognized that things that were going to come and impact their children ultimately had to be tested in the patients. And this developed a cadre of willing volunteers for clinical research. So as this grew, there were a number of new symptomatic therapies that were developed specific for cystic fibrosis, brought forward, and required clinical trials. Clinical trials in this setting could be accomplished with a large enough number to have a definitive trial right out of the gate, and they enrolled very, very quickly because the patients were eager to help us find the new therapies. So here we are in the new symptomatic therapies that occurred over a period of several decades. But during that time, research into the basic defect identified the abnormal gene, identified multiple mutants of that gene, and ultimately developed strategies for dealing with it. The first was a drug that was likely to impact a mutant form of the CF gene that was only found in 10% of patients, but we rapidly enrolled patients in the trial. And by 2012, we had the first drug on the market approved by the FDA that attacked the basic defect in cystic fibrosis. 7 years later, it took 7 years, and it took a triple drug combination, but that combination dealt with the mutant that is found in 90% of US CF patients. So you can see on this graph that from the early deaths in infancy, we're now up to a median survival age of 50 years. And I believe that with the new drugs, if they are given early in life, before there's structural and permanent damage, that we are looking at an opportunity to make the life expectancy of the CF patient approach that of a normal, of a non-CF individual. But this is all possible because the patients and their families were engaged. But it's not like that for everything. And it's not like that for things that are profoundly impact the health of the American public. There has been no challenge that has brought more into sharper focus the health disparities in the United States than the COVID-19 pandemic. This slide shows you the differences in age-adjusted mortality rates by race and ethnicity. You can see here that compared to the white population and the Asian American population, the Black population, Hispanic population, Native American population, and Native Hawaiian population had much, much worse mortality. They were hospitalized more, they were in the ICU more, and they died. And this was very disturbing, and it brought into sharp focus something that we had known for a while, that there were tremendous health disparities. So why should there be such health disparities? There are myriad reasons, but here are a few of the important ones. Patients from the Black and Hispanic minorities are more likely to live in crowded conditions. And when you have a pandemic that is a highly communicable airborne virus, being close together is an opportunity to spread the infection much more rapidly. They are more likely to hold public-facing jobs, healthcare workers, grocery store workers, bus drivers. So there is less work from home, but people who, again, who contact a lot of people have more opportunity to become infected. Unfortunately, because of the pre-existing disparities, patients from Black and Hispanic backgrounds are more likely to have the predisposing comorbid conditions that make for worse disease from SARS-CoV-2. They have less access to healthcare and preventative care. And when the vaccine became available, there was less uptake of that vaccine, at least early on in the course of the vaccine availability, despite the fact that the vaccine was free and it was made available in large public settings. And there was mistrust of the medical establishment. This slide will show you some of the underlying disparities that led to more severe COVID. This slide focuses on Black patients, but you can see that Black patients are more likely to be obese, they are more likely to have heart disease, and they are more likely to have cancer. And these things are all factors that make the COVID infection worse. In addition, access to healthcare is worse because Black patients have a larger proportion of individuals who are there without health insurance. I would also say that some of these discrepancies exist because we have not been assiduous in enrolling Black patients in clinical trials, especially for major diseases. In cancer, for example, it's been difficult to enroll enough Black patients in the clinical trials. And more recently, with the onset of personalized medicine, there are too few Black patients for whom the cancer genomes are calculated, and so that we can immediately apply what we learn in other settings. We developed vaccines for COVID very rapidly, and when they were released in late 2020, there was great uptake in Asian populations and acceptable uptake in the white populations, but not in the Black and Hispanic populations, where you can see there was a significant lag in vaccination uptake. This improved in late 2021. It may be that the vaccines were finally removed from emergency use authorization and became fully authorized for use in August of 2021. And this relieved patients from the concern that they were still somehow experimental and that if they received one, they were becoming a guinea pig. In 2022, political objectors became the dominant non-vaccinated group. And by late 2022, the death rate from COVID was higher in whites. Now, using data that they collected in April of 2021, so that's in the point where we still have significant disparities there, a group at the University of Maryland tried to analyze the causes for racial disparity in COVID vaccination rate. They found that income mattered. There was less disparities in high-income counties than there were in low-income counties. Education mattered. There was less disparities in areas where there was less disparity in education. Political ideology mattered. The proportion of Black residents in the county mattered. But surprisingly, these factors seemed to be more important than vaccine hesitancy itself. Now, this group also compared COVID vaccine hesitancy with vaccination rate disparities, with flu vaccination disparities. And of all of these things, political ideology was the only one that was significant for flu vaccine. And it was a much smaller impact than it was for COVID. This brings us to the public face of explaining the research into vaccines, the research into COVID, and how it is communicated. We're all familiar with social media and the political statements that are made. It's very hard to stop these days, rumor and false claims. And I think if we look at the quote from Mark Twain, it's been hard to stop rumors for a long time. More than a century ago, he remarked that a lie can travel around the world and back while the truth is still lacing up its shoes. But the other thing that's been true for a long time is embedded in the Jonathan Swift quote, which is that once the lie is out there, falsehood flies, and as the truth comes limping after it, so that when men come to be undeceived, in other words, when the truth is accepted, it's too late. The jest is over and the tale has had its effect. So there is embedded in the back of the brain, even when the truth comes out, problematic memories of complaints about some of the things that we know to be true. So I think that social media and politics are things that we have to consider as we think about advocacy. I think that in some ways, research advocacy can immunize against the falsehoods and the rumors. And that's one of the reasons I think it's so important. It's not just that by communicating with the community, the researcher, you can design the relevant studies, the things the community wants to know, and you can communicate your own research more effectively. But if you establish that communication, and it can be two ways. Two-way communication is very important. You need to take the pulse of the community and understand how they are thinking and what their concerns are. I think listening is as important as talking in the advocacy realm. I think a knowledgeable community is going to understand research better and will also have a better ear for the truth. It's not a permanent inoculation and it has to be kept up, but this is a way in which we can deal with, prepare the community to understand what's coming out of our research. I think that support from the community does encourage research funding and allows us to continue our work and allows us to make our discoveries relevant to the health of the community. We need to be connected to the community to understand what's most relevant and most important. And of course, it does promote participation in research. In summary, I think that as we saw in cystic fibrosis, trust in the healthcare and research team leads to participation in clinical trials, drug advances, and uptake of proven therapies. You can't have the trust without communication. or without faithfulness, consistency, and repeated contact. It is earned, but it takes time. Prior bad experiences can linger in people's minds, and falsehoods are very hard to stop. And these delay advances in healthcare and sometimes abrogate them completely. Public information, the statements from the CDC and the White House and Congress are very important, but people tend to believe their own experience. So those of us who have patient populations and have connection with the public and have the opportunity to do these one-on-one or one-on-a-group contacts, this is very important for improving the belief in research and the understanding of research. I think in many ways, it's up to us. And I would like now to turn it over to Dr. Gullett, who is going to talk about the broader problems that lead to, that complicate the research and the health of America. Heidi?
Thank you so much, Dr. Davis. It's such an honor to be here to celebrate you, and I'm so humbled by the invitation to speak with you. I wanted to share that the reason that I am able to do this work as a family and public health preventive medicine physician is that Dr. Davis, when she was dean 10 years ago, created a position working with our local health commissioner in the largest local health jurisdiction in the state of Ohio, which is Cuyahoga County, where Cleveland and many other municipalities are located. And she created a position to support me to do community and public health work and ultimately develop collaborative research with our local public health departments. And so that has led to one of the projects we're going to talk about today as an illustration of engagement with the community. Next slide, please. So I'm going to just spend a couple minutes talking to you just a little bit about grounding. Most of the audience watching probably has seen some version of social determinants of health or structural determinants of health. But I'm going to talk a little bit about one of our projects that really works what we call upstream. It's really looking at how do we get at some of the conditions that create contexts in which we see these differences in health outcomes among certain populations, so those disparities. And I'm going to talk to you a little bit about how we think that those systems and structures can be changed. And we know that there are reasons for that. So we're going to try to give you some idea of how we're doing that through community engaged research. This comes from New Zealand, but it's one of the illustrations I actually use with our first year medical students and have for a long time, which really helps see how people, we, us, all of us, we live, work, learn, and play in really complex adaptive systems. There are many layers of context that impact how we are healthy as both individuals and as communities. And so it can be somewhat overwhelming. You know, I'm a family doc. I see patients one-on-one. I see families in the office, and it can be really overwhelming to think about how do we impact the bigger system that in which these folks are living when in reality, I have this short office visit with them. But that's the other side of the community engaged work that we do at our Center for Community Health Integration, is really thinking about that system and how we impact all of these layers. Next slide, please. We also ground this in the context of what's called whole person health, which is essentially just thinking about all those layers of context you saw written out in the prior mental model. And this looks at health along with that spectrum of disease. And so a lot of times when we look at epidemiology or population health, we're thinking about that big picture, but oftentimes from a disease-oriented perspective. And this notion really says, look, we've got to consider all of these determinants at each of these levels. But we also want to think about things through the lens of what helps people be healthy, rather than just understanding disease and its causes and trying to address those. It's a both and. We need to do both. Next slide. So we here in our local community have worked hard over the last decade to develop a shared understanding of what equity is, and particularly health equity. And I'm going to talk to you for a few minutes about how we came to an understanding of what some of the biggest structural or systems drivers of health inequities are in our community. But one of the important things that we did was develop a capacity to talk to one another about what equity means. And so we really want to have an inclusive community where everyone has an opportunity to thrive and reach their full health potential. And that requires us really thinking differently about how we do research, about how we do health policy, about how we work with our local governments and public health departments to create solutions that meet people where they're at, and also take into consideration the impact, the historical impact of injustices and impacts that maybe came from decades ago, which we're seeing now. And we'll talk a little bit more about an example here in our community. Next slide. So this comes from an article in late 2021 from The Lancet. And I wanted to show this because it really does bridge what Dr. Davis talked about through with what I'm talking about at the structural and systems and population health levels. We have important science at every level. And it's really important if we're going to be thinking across the continuum of what helps people to be healthy and also how we treat disease, that we've got to understand where different science fits in along this entire continuum. And if we're really about creating places, equitable communities where everyone has an opportunity to thrive, we really have to understand all of these different pieces and how we fit together in the different types of research we do, and how we engage community at every step of the way along this continuum. I also want to emphasize the importance at the bottom of equity, diversity, and inclusion across all of those pieces. So research is, we're talking today about community engagement research, but there's also a critical component about the workforce and engaging a workforce that reflects the people in the communities most affected by the diseases or the conditions that we're trying to research and improve. And I also saw a question, and we'll get to question and answer in a few minutes, but there was one about persons with disabilities and engagement of the research community. And this is an example where inclusion here across all of these forms of research is not just based on one particular demographic, but inclusion is in the broad sense. So we may be talking about different elements, but I think that that's really relevant to that particular question about how to engage researchers. Next slide. This comes actually from the Health Affairs blog, and I wanted to put this in just as a different mental model to sort of say something similar to what we were talking about before. A lot of times in public health and public health research, we talk about upstream and downstream as if we're talking about a river. But what I wanted to just emphasize here is that we do provide a lot in clinical care, and we do a lot of amazing research, and we try to engage people in clinical trials at the individual level. But we also are trying to use tools and techniques and community engagement that's at that systems level. And so that's really what I'm going to talk to you about in the next couple minutes. And that's that community impact, the research that happens at that more upstream level. Next slide. So we have a health improvement partnership here in Cuyahoga County, which is where we are here in Cleveland. And you see that behind me. That is not a picture of Lake Erie and the Cleveland shoreline in the winter. That is in the summer, but it is actually beautiful and in the 50s today, surprisingly. But in Cuyahoga County, we have had a long, decades-long history of very unfortunate health inequities based upon race. And so we recognized that was an issue, but we also didn't know how to go about addressing it. And so this is some of the background getting us through a community health needs assessment to really understand how we tackle and use some research techniques to get at some of the systems issues that we see. Next slide. So we really did this process as a community engagement process, and I'm going to link it to the research in just a minute. But this is now our fourth. We just finished our fourth assessment since 2013. And this includes all of our hospitals and local health departments and many other community organizations. But we gather information in a variety of ways. We bring people together to analyze the data, to talk about what the concerns and the needs are, and then to come together around plans of what we do in aligning strategies to address some of these issues. And that's where some of our research comes into play. You'll notice in the bottom left corner, the prioritizations in our most recent assessment. Our newest assessment will be released actually in a couple weeks, so I couldn't share it with you here. But the prior two assessments have included eliminating structural racism as the first priority that we work on together, as this is such a key determinant of health in our community. And then trust and trustworthiness, also key to engaging people in research, was the other overarching priority in our last assessment. And that's not to the exclusion of any other health issues, which we're also addressing: chronic disease, healthy eating, active living, mental health and addiction, community conditions such as poverty, and violence. So all of those are a part of this, but these bigger picture issues that stretch across lots of different parts of our community are what we're trying to address through our community engagement and research. Next slide. So we went back to history, and this is out of the scope of today's talk for me to go through the details of this, but we went back with some partners at The Ohio State University and looked at redlining maps, which are maps of banking practices from the 1930s. And this happened in more than 230 cities across the country. And many of you may have already heard about this. But in particular, this study was focused on Cuyahoga County and looking at these past history these past historical policies and their influence and impact on contemporary health inequities, particularly based on race in our community. Next slide. So one excerpt from this, and it's a fascinating and sobering read, and I would encourage you if you have interest in this to look at its public domain. But pulling from that, we have here, and these are a little bit old data, but they're similar now. This is just what I pulled from our particular study leading up to this, is that in Cuyahoga County, you can see there's a concentration of those who identify as Black or African-American on the east side of the city. The city of Cleveland is the dark line if you're looking at the top right corner where it's blue. And then you can see the concentration of poverty based on census data. Down below, you can see the life expectancy. And in the point of this, and there's a lot of nuance and detail to this. I could have put up many other health statistics, including COVID-19, which I had in the original talk, but it was way too long, so I took it out. Is the bottom line is these health disparities, and we really move so far as to say inequities, that there is a design behind the way we see these patterns is reflective of the redlining map in our community. So we know that there are racial inequities based on the kind of opportunity people have had over years that's economically grounded, but now comes out to things like healthy access to healthy food, places to exercise and things like that. Next slide. So I also wanted to just make sure that folks know that we're talking about systems and structural racism in this particular research project, but that's not also to the exclusion of the impacts of personally mediated racism and internalized racism. So the institutionalized or structural is what I'm talking about at the top, but these others are really important. And they're critically important when we think about what Dr. Davis shared about how people in different demographic populations engage with research. And so much is grounded in trust. And these other pieces are critically important as we begin to try to engage people in research activities. Next slide. So I shared this, there's some density here. These are illustrations. I'm not expecting you to get every little detail of what I'm sharing, but what I'm trying to share with you is that as we move through this process of assessing the main drivers of health inequity in our community with a community engaged process of lots and lots of residents, so there's 1.2 million people across our community, the engagement of many people across the entire community for the feedback of what was mattering most. We also then developed a system to address what these issues are. How do we engage people? And then how do we get ongoing feedback through a research project? So one part of that was developing a systems thinking toolkit, which identifies racism as a complex dynamic system, one of those systems in which we find ourselves. And that because of these things are so complexly related and they're so adaptive over time, we can identify patterns, but we can also identify leverage points for action in order to improve population health. Next slide. So, and if you could, Dr. Davis, click through each of these so the whole thing shows up perfect. So this is a systems thinking and iceberg metaphor, and you may have seen this. This is not mine. It's used in many different teaching references around systems thinking. But the idea here is that what we see at the top are events. So we may see, a particular event happen in a community, but underneath that, there are patterns over time. And in our community, for example, we see differences in life expectancy and infant mortality compared by race. That's just one example. Underneath those patterns of time, however, there are structures, and those structures were created based upon values, attitudes, norms, mental models, metaphors. So the events we see at the top, maybe it's my patient who has an early heart attack, and dies very young. That's an event, but underneath that, there's a pattern of people in certain groups dying young for certain reasons. And so we try to really get down what's in that iceberg at the bottom and how do we address that? Because that's how we can help create a community where everyone has an opportunity to thrive. Next slide. So these are the most recent health assessment priorities. I referenced them in the earlier slide where I talked about process, but we were funded by the Robert Wood Johnson Foundation to do a research project on the structural racism and trust piece that came out of this community health assessment priority using a tool called system dynamics. Next slide. So before we got to the actual system dynamics project or research project, we identified that we had to assess where organizations were in understanding racism within their organization, understanding the terminology, the vocabulary. We did a social network analysis to understand how organizations and individuals were connected in addressing this determinant of health. And then we engaged with the Racial Equity Institute out of North Carolina to do trainings for well over 7,000 people in our community. These are 2-day trainings where mixed race, mixed gender, mixed demographics, people sit together and learn history and then begin to process their own experience with that history and then how that is manifested in their personal and professional lives. This was critical to be able to engage in the kind of community engaged research I'm going to talk to you about next. Next slide. So community-based system dynamics may be familiar to some of you, it may not. System dynamics is a way of creating a system mapping that then you utilize a computer-based model to create a simulation of what would happen when you address certain pieces in the system. So because the system's so dynamic and adaptive, it's really hard to have one particular strategy because it may impact multiple other elements of the system. So that's what system dynamics is in a very simplistic way. And we apply the community-based element of that to basically say we're engaging, partnering with community members as part of the research team to then identify where those leverage points are so that we can tackle wicked problems like poverty and racism that are leading to health inequities and unjust conditions where people do not have an opportunity to thrive and where they die young. Next slide. So important in this is that we work together at the speed of trust. And you heard Dr. Davis talk about how important these pieces are and that this takes time. These relationships are long-term, predicated on respect, mutual respect, and trust that's earned over a long period of time. So this does not happen quickly. We've been at this work since 2009. This particular research project has only been the last 2 years. But you see where there was a lot of work to get to the place where there was enough trust to actually proceed. Next slide. And just as an example, I'm nearly done. I wanted to just give you, I do not expect any of you to read this or have any clue what this says. This is here as an illustration to show you one example of an ongoing map that we continue to adapt. This was designed through group model building sessions with many community members, 2 to 3 hour sessions. I think this map came out of about 30 of those sessions where people designed their impact as they see structural racism in their community and their own experience impacting them. And over time, there were patterns that developed. And then this has been used as a basis for developing simulation models that allow us to target leverage points for action and change around health inequities that really, that are, resources are limited. So where do we put our time and energy and what are the outcomes we're most interested in getting? Next slide. So the next 2 slides are just examples. We have many different parts that have been built into simulation models from this map. And I only shared with you a slight little bit just to give you a little bit of a taste. But for example, this one causal loop diagram here shows, you can show that the simulation model has these outcomes: quality of life, criminal justice. Like in each of these pieces over many years, what are the outcomes with different potential interventions at different points in the map? And we have these QR codes built in so you can play with them on your own. Actually, they're public domain. We view this work as common good. So we want to be able to share it with other communities in case it's useful. Next slide. And then the next one is just yet another example. This is one of the ones we built out with our community health worker partners. And you can see there are lots of pieces here. And we're actually using this as a basis for an NIH application coming up later this year. Next slide. So if you want to read more, this is my last slide. This is a paper that we published earlier this year. And the point I wanted to make here is that I didn't give you a lot of background on the tool, community-based system dynamics. It's not a magical tool. It's a tool that's developed and used when there's a lot of relationship and trust and shared agenda around a common purpose. But it can be used to address these upstream wicked problems like structural racism and poverty. And so this paper that we wrote with community partners. And to me, that's a really important part of research engagement. And we also walk through the different elements of what community-based system dynamics looks like how do you structure these sessions and how does that happen? And then we talk a little bit about where we are in the process. So I just wanted to give you a reference in case you wanted to learn more. I am a couple minutes over my time, so I'm going to take it back to Dr. Davis, but thank you so much for allowing me to share an example of some community engaged research that we're working on here in Cleveland.
Well, I hope you've had some evidence that we have worked with our respective communities, both the limited communities when you want to solve the problem of a particular disease, and the broader community, particularly when you have to go after the big problem. So we'd be delighted to talk with you about anything that you're curious about.
Great. Well, we have a lot of questions and an overwhelming enthusiasm for both of your slide decks. So we hope that we can share those and we'll post them on our website. So I usually throw out a question, but I'm going to go right to our audience because we've got some really great questions here. So let's see. This is our community of peer support for persons with disabilities has over the past decade hosted 2 annual conferences for researchers and practitioners to share with our community members, and they provide a link. But this person says we have trouble convincing the researchers we contact that it is a legitimate invitation to present. What can we do to better offer our request in a way that will be more likely to be accepted by the researchers?
Well, I guess you're talking to a community here in terms of research where we've had a very strong, in our biomedical engineering department, we have a very strong program in trying to use technology to overcome some of the motor disabilities. And we have, I think, the second best funded physical medicine and rehabilitation department in the country at Case Western Reserve. So I think we would take those pretty seriously to begin with. And we've graduated a number of medical students who have significant disabilities, both acquired during medical school and students who came in with that. So how to get people to pay attention? I guess you have to work I would say maybe working by the networks, who knows who, and getting some of the people who are sympathetic to go out and recruit the other people. Heidi, do you have a good idea for that?
Yeah, no, I absolutely agree with that. I think one of the things that we've done here locally is to agree on a definition of inclusion and to have that be broad and to share it consistently and ensure that we never lose sight of that message. So as a public health doc, a lot of times we say, wash your hands. And then the media asks you another question, you say, wash your hands. And you keep doing that over and over and over again, right? Now, maybe it's wear a mask, right? Well, the same thing I think is the case with inclusion is, my internet paused for a moment. I think the same is true with inclusion is ensuring that you have that persons with disabilities as a part of that, as our gender identity, sexual orientation, race, ethnicity, language, country of origin. I mean, I could go on and on, but inclusion, neurodiversity. I mean, it's really important to have that shared definition and keep going after that same group and just keep on with the message.
In terms of faculty involvement in community outreach. And this might be less for public health, where it's kind of more standard, and perhaps more for the medical school and some of the harder sciences. How do we encourage researchers to do that outreach vis-a-vis how they are being evaluated? So, has Case Western put a premium on that community outreach in terms of promotion and tenure decisions? Are there things we can do structurally throughout academia to encourage more of that public engagement?
Well, I'd like to make a couple of points. In the first place, at Case Western Reserve University School of Medicine, the very first block that we teach the students is a community block. And when Heidi was talking about her work with the medical students, she used to organize that block. And I would also point out that when the COVID pandemic hit and all the medical schools closed down at least briefly, the medical students lined up following Heidi like a Pied Piper. And Heidi was in the Cuyahoga County Board of Health and went to the Cuyahoga County Board of Health and volunteered in whatever capacity they could serve. And since we have a diverse medical school class and diverse beyond the usual definitions of diversity, we had students who spoke many languages, and Cuyahoga County has many ethnic enclaves. So if grandma from Romania only spoke Romanian, well, golly, we had a medical student who spoke Romanian and could man the hotline for those things. So I would say that, first of all, we make it clear that this is a value for us by putting it up front with our medical students. Second, in about 2006, the medical school put in the concept of team science as being a valid criterion for tenure, for promotion and tenure. We changed two things. One, we said that the tenure line was going to be a research line, but we also said that not only individual achievement was important, but team achievement was important. And a couple of years later, because our committees were struggling with it, we put out a couple of page document that showed what you had to demonstrate to show that you were a valued member of the team. Now, this is teams in general, and it doesn't necessarily say community teams, but we have also been, I think that one of our faculty members, Jackson Wright, led the All Hat study a number of years ago, gosh, it's close to 20 now, that discovered that the order of addition of antihypertensive drugs is most effective if it's different for Black and white patients. And he led the SPRINT study. And one of the very impressive things about the SPRINT study, which showed the tighter control of blood pressure is more advantageous than even 140/90. But they had a very large body of Black participants, Hispanic participants, and elderly participants who tend to be overlooked in all of this. And the older I get, the more concerned I am about ignoring the impact on elderly. So Heidi, maybe you're closer to the promotion and tenure process. So.
Yeah, so I know we have other questions. I'll be quick, but I did want to add, yes, I am a person who has applied for tenure through the team science track. And also I think it's important to recognize that those in positions of leadership, such as Dean Davis, have advocated for not those who maybe didn't enter in a tenure track, such as myself, to then have that opportunity as we've transitioned our careers. So I think those are key for academic institutions to think about. The other piece is that in medical schools across the country, there's an increasing desire, and LCME is probably pushing some of this, that health system science is taught as a key science. And so that's really key, because community engagement and understanding of social and structural determinants of health are essential in that. And so now those are key elements of the medical school curriculum. And so we have our students out in community experiences from the second week of medical school, and that's part of our health system science curriculum. And so that's not just our medical school, that's, the AMA has an amazing health system science initiative. So I just wanted to put that out there as another way of thinking about how we train, individuals in medical schools, particularly around health system science and research.
Great, thank you. So here's another question. I'm an urban and environmental anthropologist, and I invoke systems concepts in my work, but I've gotten pushback from other social scientists that is too mechanistic, erases identity and agency. Have any of you encountered that, and what responses can you offer?
That's Heidi.
Okay. Yeah, so I really appreciate that question. And I too have had some similar conversations. I think my response, I'm learning over time how different people conceptualize the use of system science, but my response is often that we cannot solve these very complex structural determinants of health through reducing things to their parts. It's just not possible, because the impact within these dynamic systems cannot just be a linear impact. And so we've got to understand where those leverage points are for these systems. I do think you run the risk of losing identity and losing agency, but through community-based system dynamics, what we have done is, not that we have it all figured out, but we have very long-term relationships with many different community members who are part of the research team. They are the folks who are identifying what the system looks like and where those leverage points are. And I think if you engage people most proximal to the issues you're trying to address, you're trying to think of things through an equity lens, that really addresses the issues of identity and agency. You certainly have to understand it, and you always need to be astute to it. But I would say that engagement has been essential in addressing the things that you talked about. You just cannot reduce these issues to their parts, nor can I, as a white physician researcher, go into a neighborhood in our community and identify where the issues are and where things need to be addressed. And so that's been really important. And I think something that we have seen is that our partners have taken these maps and gone literally to community meetings and said, look at what racism is doing to our community. And they're explaining the maps that they've created. They're designing the solutions. They're designing the impact. That's what we're looking for. And that really addresses the issues that you're talking about.
Do you think that you come from a region where there are very strong community-based organizations? And has that been helpful, right? You know, and I'm also thinking about former Congressman Lou Stokes. And when I served in, you know, when I was a staffer on House of Propes, he was on the Appropriations Committee and was such an incredible champion of his region, but also of health disparities. Yes. I mean, that was really his legacy. So many of the programs in the federal government at this point, which are better funded than they were, you know, at the time, but have really grown, were established by Congressman Stokes. So I'm just wondering what might be unique about your region that might be helpful in this way, and perhaps how can we build some of those structures in other communities? Heidi, go ahead.
Okay, I want to defer to my mentor because she has so much wisdom. But I can tell you that I don't think in Cleveland that we're any different than elsewhere. We have a very strong legacy of community-based organizations fulfilling needs that aren't met by governmental resources or otherwise. But we also live in a community where there is a lot of competition among not-for-profit institutions, including in healthcare. That is no secret to anyone. So we found ourselves in a situation beginning this work where it wasn't really accepted to talk about racism in organizations, even in not-for-profit community-based organizations. So that was part of that onboarding building process, creating a vocabulary, getting people to understand they can talk about this, the organizational readiness. But then the next piece was actually building trust between organizations, not just with community members. That was really important too, but also between organizations, because often you'll be in a room and somebody from another competing organization, even in the not-for-profit space, you're like, what's their agenda? What is their agenda here? And so we've often very overtly said, we take off our organizational hats in this collective space. And we are here working toward the collective agenda that we've designed together. And that was why it was so important for us to get our community health needs assessments and our community health improvement plans collaborative and being done together. Because otherwise you get these splintered effects and you have people almost competing for, people for advisory boards and other things like that. And so I would say we have strong support, but we also have this really interesting culture in this community. And so we really had to work against that. And one of the things that we do is we have partnership rules and meeting rules, and we put them up every single time we have a meeting. And that's about minimizing power differentials. It's about coming with, assuming the best intentions, those sorts of things. And some people thought it was silly at first. Now they expect it. If someone doesn't do it at the beginning of the meeting, they're like, we didn't go over our partnership rules, right? So these are things that we brought up together. So I think that you can't underestimate the value of those sorts of things. And then we also end every meeting with gratitude. So it really helps us bring the humanity into the work.
So I would say one other thing about Cleveland, and that is that we have a disproportionately large community foundation in the Cleveland Foundation, which has placed racial equity and community benefit at the very top of its priority list. And they are disproportionately large for the size, financially, for the size of our city. So they are able to exert some clout over some of the areas of the town that perhaps we could not do on our own.
That was going to be my question, the role of philanthropy. So thanks for answering that. I had a feeling that the philanthropic community was involved. There's a lot of focus on how do we diversify talent in STEM. And I wonder if your community outreach has led to a greater number of students from minority communities, from Black and Brown communities, to be interested in science and pursue different types of science careers.
Well, we are working at a very grassroots level. We started at the high school level. There is a Cleveland School of Science and Medicine that our medical students mentor students at and tutor at. And we have a scholarship program that takes one student a year, free ride through Case Western Reserve, and if you get a certain grade point average, a free ride through medical school, and you're guaranteed your acceptance. The university has agreed that anyone who comes out of the Cleveland Metropolitan School District gets a full scholarship. So that is very helpful. The Science and Medicine School on the west side is now located within Metro Health, the Metro Health System hospital. So there's a natural tendency, a natural bent to developing people's interest in medicine. And we take a significant number of students from St. Martin de Porres, which is part of the Cristo Rey network, the Catholic network around the country, where students who are very poor go to school and work one day a week and get paid to support their education at St. Martin or St. whoever in the local thing. So we take a significant number of student employees from that. And recently there's been a Jobs Ohio program that I believe is based at the Cleveland Clinic to train people from the community to become medical assistants, EKG technicians, everything in that level of healthcare, and to move to use that as a springboard to moving up. So that, I think, is also there. Heidi, you can probably expand on that.
Yeah, no, I agree with those examples. We also do some research addressing poverty, and particularly poverty in primary care. And I didn't address that today because we only had time for one example. But one of the things that we've done in that research study is actually link our first year medical students up with some of the students who are engaged in that program. And they spend a year as a mentor with those students, meet with them at least monthly in the school where they attend. And then our medical students would often give a monthly talk as well about healthcare careers or other things. And so this became very relationship based and an opportunity for a positive impact in their lives where, and oftentimes these were our, wasn't just underrepresented students that were these mentors, but a lot of times the students were seeing people who looked like them in positions they might want to pursue, and that really is important.
Well, we have come to our time. And we didn't get to all of the questions, but we got to most of them. I can't thank you both enough. Dr. Davis, I think it's clear to anyone who tuned in today why you were deserving of the Herbert Pardes Family Award. And Dr. Gullett, we're so glad that you joined as well. Your work is so inspiring. I hope folks on today's Zoom will join us next week when we have a discussion with another awardee, Dr. Margaret Hamburg, who is the recipient of the Research America's 2023 Outstanding Achievement in Public Health Award. So a link to register is in the chat now. We will be making this session available on YouTube and distributing your slides as well. So thank you both so much. I learned a lot, and I know folks in our audience did as well. Keep up the amazing work that you're doing, Dr. Davis and Dr. Gullett. Thank you.
Well, thank you for the opportunity to speak today.
Thank you so much.